It's my pleasure to be here. Someone once pointed out to me that if you paid priests by the prayer, there'd be a lot of prayers said. If you were paid by the prayer, how many could you say in a day? Anyone want to guess? Is there any mystery why we largely overuse medical care? We're paid by the prayer. But what will we do about it? Well, I'm going to share with you some sort of unconventional, perhaps, thoughts and some interesting data. But let's start. How many people here are or have been married? So let's see. Keep your hands up. For how many? Come on. There's more. Okay, there you go. Now, how many of you did this as a thoroughly rational choice with decision analysis? Oh, there are four who claim a proper decision analysis. The rest of us are fully human and make our choices largely out of emotion, intuition, and habit and social cues. And that's a piece of what I'm going to try to get into here. I've long been fascinated by the ability of humans to turn our backs on rationality. It was one of the gifts we were given, but we often make our decisions very much like farm animals. Whatever it is that's in front of us, we do. And, so we pursue the illusion that if we could only get good information and good decision-making, everything would turn out right. And I'm here on behalf of the idea that that might not be the case. We know it's not really true. There are too many people making too much money. There are too many people well established. There are too many cues in the culture. We know that merely giving good information and good decision making is not going to get right care itself. But let me give you a few examples of what I mean. A couple of years ago, number of years ago now, I was serving a nursing home, and a lady came to join us who was 96 years old. She arrived in florid congestive heart failure and nearly died that night. We did old-fashioned rotating tourniquets and hospice care, and she somehow managed to find a physiologic stability and lived for 2 more years. She was moderately demented as she arrived and severely demented by the time she died, but she loved to fold towels, and the aides would give her a big stack of towels. She would fold them. She would feel like she was contributing to the community. She got a lot of joy out of folding towels. The aides would go around behind, shake them all out, give her a new stack of towels, and she was delighted. And then one day, she just sort of was off. She wasn't eating quite right. She sort of took to bed, didn't seem quite right. I came and examined her, didn't find anything terribly important, and the next day she died. And as we had the habit of doing, we offered an autopsy. I bet not very many of you had the habit of doing that. But we offered an autopsy, and the family agreed. So she had her autopsy, and a couple weeks later, I sat down with the family to tell them what we'd found. And what we had found was a bleeding gastric carcinoma. And her one daughter, remember, both daughters are in their 70s now. One daughter said, we all sat down and we were talking about it, and I told them about this finding, and the one daughter said in hostile anger, "You missed it. How could you possibly have missed a cancer?" And the other daughter gently put her arm on the first daughter's arm and said, "You know, Mary, she couldn't have had a better life or a better dying. We would only have made her miserable." Isn't that true? How could we have done any better than what she had? 36 hours of what turned out to be serious illness and a gastric bleed. Not a bad way to go at 98 with substantial dementia, and enjoying every day folding towels, whatever turns you on. So anyway, she, what have I done here? I want to tell you another story. This is a problem whenever I've never written a speech before, but Lown wanted me to really work on this speech, so I wrote it. Now I don't know what to do with a written speech. But in any case, she was clearly quite wise. The second sister was quite wise. I want to tell you about my son. I have a wonderful grown son. He did well, but at 5 years old, he was found to have a rhabdomyosarcoma. Now, through a series of very odd things, which I'd be delighted to tell you over a drink, we found this thing at the smallest that it had ever been found. It was less than 5 millimeters across. He had the full scanning workup, and despite all that, the protocol insisted that he have a full laparotomy with sampling of various lymph nodes. I objected. I said, come on, this protocol was set up at a time you didn't have these scans. He's now had all these scans, there's nothing showing up. Let's let it be. No, we have to do this. And we ended up getting bullied into doing the full laparotomy, which incidentally nicked a vessel and killed off half of one kidney. But then the story gets even worse. So now he's supposed to go on chemotherapy for the possibility of spread, having had the primary removed. And I do a little bit of work and find that the protocol in Europe is so much more gentle. There's no germ cell line toxicities. The toxicities are very much less, and they're getting the same good results. And remember, he had the tiniest one going and has now had a full lap. So I said, why don't we use the European protocol? First, the oncology fellow told me that there was really no option to the protocol for rhabdomyosarcoma. I said, well, you've given me this 35-page research consent form to sign. What happens if I don't sign it? She said, well, we'd have to take you to court for child abuse. Take me to court for child abuse? Come on, there's no alternative to a research protocol? There's no alternative to a research protocol. I talked with multiple people who were leaders in childhood cancer, and it turned out that no one was willing to do the European protocol except for a cancer center a few hours away, which would mean that every time he had any complication, every time he needed a treatment, I would have to drive that distance in the snow, in the bad weather, with other kids. I mean, what was I to do? So I got bullied into using the American protocol. I will wonder through my whole life whether that was a reasonable decision. I had good information. I was much more deferential than I would be today. I was kind to all parties. The head of the ethics committee at that children's hospital told me, how will you feel when this decision is all on your shoulders and he gets a recurrence? I said, Sandy, we've been colleagues for years. The whole point of this conversation is that it wouldn't be all on my shoulders. He said, well, it sure will be, because that's all we're going to do. Okay, I had the information, I had the good decision making, and I got bullied into doing the wrong thing. I think that patients get that to happen all the time, and it's in much more subtle ways. Those are, striking ways, but in much more subtle ways this happens. Let me share with you a very old study. This is the study to understand prognoses and preferences for outcomes and risks of treatments. The support study, which I was privileged to work on back at just about the 1990s. It was 1988 to 94. The support study had two phases. One was entirely descriptive. It worked in 5 teaching hospitals. You can see the numbers there. And we described how very sick patients were treated. We did interviews with them, their families, and their doctors, learned a lot about their preferences, built a terrific prognostic model, and showed enormous shortcomings in the care process. So then we implemented what at the time, and to a large extent today, is thought to be the optimal intervention. For half of the patients, block randomized, we instituted excellent counseling. We had well-trained nurses armed with prognostic models, armed with information about the patient and family's preferences. They talked with the doctors, they charted in the chart, they talked with the patients, they tried to help make decisions work better. So these were the target outcomes. Pain was added late, incidentally, because we found such high levels of pain, we felt obliged to intervene on pain. So we measured whether the doctor and patient agreed on what would happen about a resuscitation, whether the timing of DNR orders shifted, whether the patient had many days in what would count as a difficult circumstance before death, pain, and the resource use in the hospital. The stunning result of this, when it was all unblinded, was that there was absolutely no effect. We had done the very best that anybody thought one could do. And this is the kind of thing we show, and I'll show you a series of these. So phase 1, the descriptive phase, and then phase 2, and the reds are controls and the dotted lines are interventions, and absolutely none of these are statistically significant. So the great hand of God had ironed our data flat. We had only one spurious finding to explain away, and that was because the entire colon cancer team at one hospital had left. So there was an appearance of an effect. So on all of these things, we made no difference at all. We were so overpowered, we could have detected if we had moved back the timing of DNR orders by 1 hour. We certainly could have detected it at a shift. We had no effect on any of the target outcomes. It has been difficult for people to digest that finding. Mostly people have simply ignored it. I was party the other day to a meeting at PCORI, where PCORI is planning to announce a big initiative in palliative care and end-of-life care. And the set of things that were recommended by the expert panel, 4 out of 5 were to enhance advanced care planning. I finally said, sort of 2/3 of the way through the day, you know, you might want to have people explain how they're going to improve upon the support findings. They should at least take it into account. Why do we think that the support findings were as they were? There was enormous variation among the hospitals, among the 5 settings. This gave us a lot of reason to think that there would be movement. So here you can see on undesirable days ahead of death, there was a 3-fold difference between the most aggressive life support kind of hospital to the least. There was the similar sorts, but a little less on pain, timing of DNR, and DNR preferences. So there was enormous variation across the country, but not in any one facility. Any one facility would maybe not bully you into doing what they were used to doing, but they would end up doing mostly what they were used to doing. So here's what we found were the predictors of dying at home in support. Colon cancer got you home more often, being old, the site differences, there were enormous site differences, and the regional bed supply. You know, this was a Jack Wenberg analysis, so 1 bed per 1,000 more in an area gave you a 5% reduction in dying. One bed per 1,000 lower correlated with a 5% higher likelihood of dying out of the hospital. But preferences of the patient and family were completely without import in figuring out the risk adjustment. So very much where you end up going determines what will happen. Support built on the widespread presumption, then and now, of these 3 things. This was in the final report, and it's in the one that's on the website for Lown. Each patient's course of care results from the interaction between the patient's illness and decisions about his or her care. These decisions require physicians, and improved individual patient-level decision-making will enhance the process and outcome. So this was the concept that guided support, guides lots of what we do every day, guides lots of grant activity, guides lots of reports in the literature. I'm here on behalf of a different perspective. But so support held that improved decision-making requires incorporating the patient's view and that the physician needs to know the patient's view. But remember that we did that and it had no effect at all. So here's an alternative. This has never been popular, but it's in the article that is on the Lown website now. The course of care may be determined largely by pre-existing routine. That patient-centered decision-making is very difficult to implement, and improving the experience of the patients might best be achieved by changing institutional and professional routines. Change what is habitual, change what is readily at hand. A few of us in the room are old enough to remember the revolution in obstetrics care. When I was in training in the early 1970s at Boston City Hospital, women still labored in a large room, unattended by anybody they knew. They were schnockered at the end. They met the baby somewhat later. There was no support for breastfeeding. It was a very much doctor-controlled endeavor. By the mid-1970s, that was anachronistic. Now, there were individual women who insisted upon doing it differently, and that was very important as a catalytic endeavor. But the big change was that by the end of the 70s, a woman who said absolutely nothing got just about the right thing. A woman who did not speak up for herself got supported childbirth, got support for breastfeeding. The habits had changed. The statements of the nurse, the statements of the janitor, the statements of the woman who delivers the food, all were different. They were all supportive of breastfeeding, of nurturing the baby, of being awake. We had changed the default in the system. Similar thing happened at just about the same time. I was quite fascinated with what happened with wills and estates. In the 1960s, if you did not have a will, even for a very small estate, all kinds of wrong things happened. By the 1980s, almost every state had changed their intestacy laws so that if you, again, said nothing, just about the right thing happened with your estate. It went to your spouse, and if there wasn't a spouse, it went to your children, and there were rules about exactly how this would go that mimicked the dominant preferences of people. So the default assumption changed. That default assumption is terribly powerful. So what we learned from doing all this was that prognoses stay ambiguous until very late in the course. You can know you have an illness that will kill you, but it is very difficult to know when. So almost everybody had a prognosis higher than 50% to live 2 months in what turned out to be their last week. Remember, support had a median age of 65, so this was not 90-year-olds. We had this marvelous video of a husband sitting by the bedside of his wife, and she's told she has a 20% chance to survive, and he says, "Here's my 5 fingers, honey. Stick out your hand and grab onto one. We're gonna make it. You've got a 20% chance." We thought a 20% chance was really pretty grim. He saw a 20% chance as a lifeline. There was still a door open. There was still a way to make it through. That's an important finding. Patient preferences are generally not firm or firmly held, not even up against death, maybe not especially up against death. People look around for their cues. They try to fill a social role. They say, I want people to remember me as the good father. I want to be a good mother in case I die. I want to act in the way that's expected of somebody who is in this role. And so they're looking for cues as to what a good person does. How many times have I railed against those headlines in the paper that say someone succumbed after the long fight with cancer? Why is it a fight with cancer? Why is it the battle with cancer? Why is that the only thing a journalist can call it? Why isn't we now are starting to say a battle with Alzheimer's? I got to tell you, I don't have very many Alzheimer's patients who do battle. It is a really weird metaphor in that circumstance. We use DNR as a symbol. DNR was a symbol that we're all together in understanding that the patient is going to die. It wasn't really a decision about resuscitation. It was really a social cue. Now we're all together and are saying goodbyes. So if the family objected when the doctors first brought it up, it was okay to let it ride for 12 hours or 24 hours. They were going to come around. It was this social interaction that had almost nothing to do with the quote decision itself. And there were enormous differences between the most, what I would call aggressive, and the most supportive hospital. So actually, I wanted to tell you just a little about that. I thought I put it on a slide. So I want to tell you what we, in the support hospital that had the highest rate of out-of-hospital death, physicians usually followed their patients to home. So they had the same doctor in the hospital and at home. And everybody knew each other. So the nurse in the hospital would say, oh, you're going home to Janesville. My good friend Susie is the head of the home care service out there. Say hello, and they're wonderful. Everybody knew each other. The hospital that got most people home, the jobs were protected for potential caregivers. The cheese plant would welcome the person back when they came back from caregiving. The seamlessness of the system was quite obvious. The family member would be sitting by the bed when you went to make rounds. There was not a long time in figuring out who would provide support at home. There was only one service. In the hospital that was the most aggressive, not a single doctor held a DEA license for out-of-hospital prescriptions. Not a single doctor could write a narcotic prescription for the person being discharged. The out-of-hospital doctor had to do that, guaranteeing a dysfunction over the transition. Not a single doctor followed patients at home. Some followed them in the clinic, but nobody at home. Not a single doctor served a nursing home. The patients' families were mostly blue-collar workers. If they took off more than a few days, they would lose their jobs. There was no job protection. If a person died at home in that hospital, the homicide squad came to check it out. In the other hospital, the neighbors showed up with casseroles. The difference was enormous. And there was no way that a patient's choice could make Hospital 1 behave like Hospital 2, or Hospital 2 like Hospital 1. The patient was caught in the social system that had been developed. And I think we all too often forget how important that social system is. So what should we do? I've been working a long time now on frail elderly people. And I'm going to skim through this fairly quickly, but I think it's the kind of thing that might really make a difference. So we're working to make sure that those of us in the room, when we grow old and frail, and most of us will, the average duration of self-care disability now is about 2 years. Most of us will have that experience. So how can we get through that part of life with meaningfulness and comfort without running up incredible bills? Remember that we are becoming an aging society. We actually have fewer children than we had in 1955, but we have many, many more frail elders. So how are we going to keep out of big trouble? We are going to first recognize this part of life. We're going to build a care system that does individualized care plans, makes it possible for geriatric medicine to be supplied, especially at home, bring social services into the net as real services. I was in Detroit recently. There's a 1-year wait for Meals on Wheels. If there was a 1-year wait for mitral valve surgery, we'd all be up in arms. A 1-year wait for Meals on Wheels, and we don't even put it in the newspaper. We need a community board that manages this system, that notices what's happening, that measures and monitors, and even just brings to public attention what is oversupplied, what is undersupplied, what has quality problems, where our priorities are. And what's interesting is that at least for the next decade or so, in most parts of the country, you can fund the reform on the waste. Waste and low-value care in Medicare is just enormous. We have built a social services system that is completely separate from our medical care system. We do not have an integrator, and therefore we get inappropriate, unreliable, unmanaged, wasteful care for this phase of our lives. With a sweep of my pen, I can write for a $100,000 drug for my most demented nursing home patient. But I cannot get Meals on Wheels on a weekend. I can't get a substitute caregiver. I can't fix the fact that there's a 1-year wait for Meals on Wheels in Detroit. We could measure these sorts of things as a public health measure. This is the public website in Sweden. Measures 20 elements of end-of-life care. You better believe that if you're in a municipality that's lagging behind another municipality, it comes up at the county council meeting. People say, why are we providing psychotropics twice as often? Why do we have pressure ulcers twice as often? Why do we have care plans that aren't being implemented? They're measuring these things as a public health issue. We do not combine things as a public health issue regarding the frail elders at all. You can't tell whether we are getting better or worse in Chicago than we were 5 years ago. We can tell whether a particular nursing home may be performing better or worse, but you can't tell whether Chicago is doing better or worse because we haven't cared to do so. So we need to make these major reforms within current dollars. So where will the money come from? I have to tell you, it's from the most banal of sources. This is my mom when she was 90, 5 years ago. She broke her back. She picked up a little suitcase, felt something give. She had been a radiologist. She went into the emergency room saying, "I've fractured D12." The ER guy said, "No, you have a urinary tract infection." She said, "You're full of it." She came back 12 hours later, got the right diagnosis, got the one x-ray she needed, and was sent home to let this thing heal. The best treatment for a compression fracture in a 90-year-old is rest, exercise, mobilization. What did she get? She got every imaging study known to man, despite my objecting to all of them. She said, "But they're concerned as to whether this might be metastatic cancer." I said, "Mom, at 90, what's the advantage of knowing it's metastatic cancer 2 weeks early? If you start feeling better, terrific." And then, the 0.001% chance that it's metastatic cancer in the presence of thoroughly normal labs and no sign of cancer is worth finding out in 6 weeks. But she got every imaging study known to man. She got a corset made, carefully measured, elegantly made, would have fit Magic Johnson. Sitting on the chair next to her, it came to her chin or beyond. Never used, $1,000 run to Medicare. The orthopedist desperately wanted to do vertebroplasty, inflate that vertebra. Only thing I know of that has had 2 shams trials showing that it has no good effect but fractures the vertebra above and below a little more often. That finally convinced her to go against her orthopedist's suggestion. Thinking she might fracture anything else was clearly off the table. But that would have run up the big stack of bills. What did she need? She needed a little home care. She needed a good home care nurse to show up and make sure somebody was bringing in food, make sure her bowels weren't locked with the opioids. She needed TLC. That would have saved all that money. That's the kind of waste we have in Medicare. Yes, there's also big-time waste, but there's little waste. Turns out we've done simulations in 4 communities. Milwaukee, incidentally, is a suburb of Portland, Oregon, so it's in a very skinny healthcare system. Everywhere we look, there's enough money in the system to fund the reform. Return on investment looks very good by the 2nd year everywhere. There is enough money in the system to make the reforms happen, at least for the catalytic period of the next 10 years. We could learn how to take care of one another effectively. So what to aim for is a fully integrated system with honest care plans to aggregate the perspectives and have that guide the system, change the default, change what it is that happens if you don't speak up, make sure that you know the unusual beliefs and situations that people are in, and make care plans that work. And you can sustain all this by reinvesting the savings. Right now, all of the programs that Medicare offers that provide for savings go to wealthy people. They go to well-off providers, or they go to investors. Not a single penny is reinvested back in the community. There's something outrageous about that. We think that you could do this right away through PACE. PACE is the Program of All-Inclusive Care of the Elderly. It is a tiny GEM program, serves 38,000 people in the country, over 20 years, so it's grown very, very slowly. But in a fit of inattention, had to be, Congress actually passed a statute in November. That's the inattention. I mean, they don't pass statutes very often. But this one finally put PACE under CMMI. So now PACE could be allowed to innovate. So you could expand eligibility, include Medicare-only patients, not just the duals. You could have a more flexible care model. Instead of requiring 9 assessments, you could have just 2 or 3. You could expand and the models for private payments so that people can pay for their long-term services. And then you could build on the geographic focus, make that community board really work. I think one other thing we've forgotten to do is that we've forgotten to get people angry. We are so good at papering over the problems, making things work, making it good enough for this patient. The suffering of the patient and family in front of you, you don't want to expand that. But I call on all of us to start telling people to start learning to complain, to remember to complain 6 months later when you're out of this, to go back and talk to the CEO, go back and talk to the chief medical officer, insist upon things happening better than they did for your mother. We really have to start getting people angry enough to carry the ball. This is the opportunity to engage your representatives. This is the election season. We have the opportunity to raise holy hell with our representatives. How is it that we've managed to get through all these debates and town halls, and yet no one has asked these questions? We need to really get that moving. And again, the Medicaring model is a different kind of approach. Change the default option, include patient choice, make sure good care plans happen, but that becomes the default option. So we can have what we want and need when we're old and frail, but only if we get to it and start making the system that we want to grow old in. As Buckminster Fuller famously said, you never change something by fighting the existing reality. To change something, build a new model that makes the existing model obsolete.